and welcome to Grand Rounds. My name is Joseph Hennig. I'm one of the newer hospitalists here. As you can see, I'm still in a jacket because it's very cold out there. Believe it or not, I did grow up in Rochester, but for the last several years, I've been away in residency. And thankfully, I was in a warm place, Louisiana. Anyhow, it's nice to be back in Rochester for the last 4 months or so. So thank you all for being here. Today, I'll be walking through two cases that honestly kept me on my toes and made me rethink some of my own clinical instincts. It touches on some diagnostic challenges and management decisions that I found particularly interesting and, to be honest, a little bit humbling. I'll be diving into the patient's presentation, how things unfolded, and review of some clinical guidelines. So I have no disclosures, objectives. So I'm going to start with a case review of a patient that had followed by some review of guidelines. So this was a 49-year-old male with a past medical history significant for non-ischemic cardiomyopathy with heart failure with reduced ejection fraction of 25%, hypertension, hyperlipidemia, type 2 diabetes, premature ventricular contractions, and a history suggestive of possible sarcoidosis. The patient presented to Unity Hospital with progressive shortness of breath that began prior to Thanksgiving and worsened over time. He reported increasing dyspnea on exertion and orthopnea, along with a productive cough yielding thin white sputum, but denied chest pain, palpitations, fevers, or lower extremity swelling. On arrival, his vital signs were notable for a blood pressure of 121/90, heart rate of 113, respiratory rate of 18, and a temperature of 37.1. He was saturating normal on room air. Laboratory workup revealed a sodium of 131, potassium of 4.3, magnesium 1.5, elevated troponin rising from 74 to 76. Viral panel was positive for influenza A, and his chest x-ray demonstrated interstitial opacity suggestive of mild pulmonary edema or atypical pneumonia. So initial assessment, thought a lot of his symptoms were due to an acute exacerbation of chronic heart failure, likely triggered by possibly influenza A. He was started on IV Lasix after holding hydrochlorothiazide with plans to obtain an updated echo. Depending on the results, cardiology consultation was going to be considered, and the hypomagnesemia was corrected in the emergency department, and Tamiflu was initiated for influenza A. The following day, the patient reported ongoing mild dyspnea at rest and continued orthopnea. An initial bedside echo showed persistent severe global hypokinesis with an estimated EF of 10 to 15%. At around 9 a.m., the patient was noted to be diaphoretic at the bedside, which he attributed to walking to the restroom. His shock index was 1.1 with a systolic blood pressure of 127 and a heart rate of 103. I took that to be that he was hemodynamically stable at the time. However, by 14-16, he became hypotensive with a systolic blood pressure of 95 and a heart rate of 103. A second bedside echo performed by cardiology reconfirmed the low EF, prompting an immediate right heart catheterization, which showed a cardiac index of 1.65 and elevated pulmonary capillary wedge pressure of 26. A Swan-Ganz was placed and vasopressor support with norepi was initiated to maintain a MAP above 60. He was transferred to the ICU, and despite his initial hypotension and tachycardia, he stabilized with only 2.5 micrograms of norepi weaned off after about 10 hours. It demonstrated adequate urine output and stable renal function. A repeat echo showed a slight improvement in ejection fraction to 20%. Cardiology initiated guideline-directed medical therapy, including low-dose metoprolol, Jardiance, and plans for outpatient evaluation of possible cardiac sarcoidosis and an ICD placement. During his stay, the patient experienced intermittent episodes of non-sustained ventricular tachycardia, necessitating further monitoring and coordination of LifeVest placement before discharge. Potassium and magnesium were repleted as necessary. Eventually, the patient was discharged with a comprehensive plan. He was prescribed metoprolol, Jardiance, rosuvastatin, and magnesium, in addition to his other home meds. The LifeVest was arranged for outpatient monitoring arrhythmias, and follow-up with advanced heart failure and pulmonary clinics was scheduled. Additionally, a cardiac MRI was planned to evaluate for cardiac sarcoidosis. The patient completed a full course of Tamiflu for flu, etc. So in summary, after initial stabilization for cardiogenic shock, his ejection fraction improved from 10 to 15 to 20%, and his arrhythmias were managed appropriately throughout the hospitalization. He was discharged stable, I think with a great follow-up plan moving forward. And I've been stalking his chart just to see, he made it to his PCP, cardiologist, EP, and pulmonology. Although previously he had been lost to follow-up for about 5 or 6 years. So since discharge, he hasn't had the cardiac MRI yet. I don't know how long that process usually takes, but after all of this, I wanted to look into quite a bit diagnosis and approach to cardiac sarcoidosis. And I essentially came up with, from looking at UpToDate and multiple different sources, what kind of context you would be suspicious of cardiac sarcoidosis possibly. So someone presenting with persistent palpitations or other suggestive signs such as unexplained syncope, heart block in individuals under 60 years of age, sustained ventricular tachycardia without a clear cause, or specific structural abnormalities on echo like regional wall motion abnormalities or basal septal thinning. But the key here is that these symptoms should prompt consideration of sarcoidosis only after more common conditions have been ruled out, like ischemic heart disease, electrolyte disturbances, medication effects, and other cardiomyopathies. Once those more prevalent causes are reasonably excluded, cardiac sarcoidosis becomes a plausible differential, especially in cases with unexplained heart block, sudden cardiac death, in young individuals, or other unexplained cardiac dysfunction. So this algorithm here is an adaptation of the AHA's algorithm approach to diagnosing cardiac sarcoidosis, with some other additional input from a few other societies. There was really no universally agreed upon diagnostic criterion for cardiac sarcoidosis, and from what I found, there's a lot of different nuances. In fact, the AHA's clinical diagram is annoyingly complex, and UpToDate's is just sort of a huge block of text. As an internist, not a specialist, I need a straightforward approach. So I'm not saying I'm dumb, but maybe comparably, I don't know, I digress. I simplify the process to create a practical tool for my own clinical use. So the first step, does the patient have extracardiac sarcoidosis? And why this matters is intuitively the presence of extracardiac sarcoidosis is critical because firstly, patients with that will have a higher pretest probability of cardiac involvement. Secondly, sarcoidosis is a dynamic disease and extracardiac manifestations may appear or disappear over time, and active inflammation in the heart can fluctuate. As this study shows, endomyocardial biopsies generally have a low sensitivity due to the patchy and irregular nature of inflammatory lesions. But there were some predictors of a positive sample. Anywhere from 20 to 70% of patients with systemic sarcoidosis will have cardiac involvement. Though many cases are subclinical, autopsy and imaging studies reveal cardiac sarcoidosis in 20 to 29% of systemic sarcoidosis cases in the US and up to 58 to 70% in Japan. Briefly, to confirm extracardiac sarcoidosis on the basis of clinical criteria alone. The ATS only recommends considering the following conditions as pathognomonic. Lofgren syndrome, where you have erythema nodosum, these pictures here, in combination with bilateral hilar lymphadenopathy and arthralgias. Lupus pernio, which is chronic bilaceous and indurated plaques, typically affecting the nose, cheeks, or ears. And Hereford syndrome, which is facial paralysis, parotid gland involvement, and uveitis. Hypercalcemia can also be highly suggestive, but not pathognomonic even when the PTH is low and the 125 vitamin D is high in the right clinical context, as well as biochemical markers like ACE levels are high or serum soluble interleukin-2 receptors. Other systemic manifestations should also be looked for, such as hepatic involvement, uveitis, or neurologic symptoms. Additionally, imaging with high-res CT can uncover occult pulmonary sarcoidosis. Some experts, such as Bernie, whom I was watching speak at a 2024 Rare Cardiac Conditions Conference on YouTube, noted often whole PET scans with appropriate metabolic preconditioning are used to help find suitable areas for biopsy when you're really looking into possible extracardiac sarcoidosis. So on comprehensive evaluation, the majority of individuals with cardiac sarcoidosis will demonstrate systemic involvement, underscoring the need to perform thorough organ assessment. This brings us to our next decision point. If extracardiac sarcoidosis is present within this clinical context, you proceed with a cardiac MRI on the right. If extracardiac sarcoidosis is absent, you've conducted a thorough evaluation to exclude extracardiac sarcoidosis. Only if there's still high clinical suspicion, such as someone who has unexplained heart block and they're less than 60 years old, or idiopathic ventricular tachycardia, then it's recommended to proceed still with a cardiac MRI. So regardless of extracardiac sarcoidosis status, it is recommended to begin with a cardiac MRI with gadolinium enhancement. And for this is the cardiac MRI has a sensitivity of about 88 to 100% and 85% specificity for detecting cardiac sarcoidosis. Of a side note, some institutions are starting the workup with a combined cardiac MRI and PET, but based on recent meta-analysis, which was lacking in the PET MRI protocols to evaluate, showed that there were sensitivities reaching 94% with a confidence interval of about 84 to 100. Therefore, in view of cost effectiveness, I think it's best to proceed with the cardiac MRI first. So on cardiac MRI, there's late gadolinium enhancement, which uses T1 weighted imaging with specific pulse sequences to highlight areas of fibrosis or inflammation. I found it kind of interesting how it works. The key sequence is T1 weighted inversion recovery gradient echo. Gadolinium essentially hangs out in diseased areas of myocardium, whether inflamed or fibrosed, longer than healthy. Therefore, gadolinium both has more room to soak into unhealthy tissue and drains out slower, as shown by the larger bucket and the smaller bucket, but both still washing out slowly. So gadolinium then drains the energy in the diseased tissue, causing it to lose energy rapidly. And this difference is noted in the MRI imaging. It appears as a bright intensity where the normal tissue appears black. So you can see this white intensity here, normal tissue appearing black. And at this spot, the intensity difference is. So this diagram, it comes from a systematic review and meta-analysis by Okasha et al., who analyzed gross pathologic images from patients with histologically confirmed cardiac sarcoidosis who underwent either autopsy or heart transplantation. The study aimed to identify consistent patterns of heart involvement in sarcoidosis by compiling and analyzing published pathological images. Before diving into the findings briefly, I wanted to remind myself last night that the endocardium refers to the thin innermost layer lining the heart chambers, lying just beneath the pericardium. Then you have the thick myocardium and then the epicardium lying beneath the pericardium. In ischemic heart disease, damage typically starts in the subendocardium. The deepest layer of the myocardium, because it's the furthest from the coronary blood supply and most vulnerable to oxygen deprivation. Damage then spreads outwards toward the epicardium as ischemia worsens. In myocarditis, the injury primarily affects the mid-myocardium due to inflammation, often from viral infection. In contrast, cardiac sarcoidosis behaves differently. It creates patchy, non-territorial damage that doesn't flow the heart along the heart's blood supply. And instead, it often begins in the epicardium or septum and spreads fairly unpredictably, reflecting granulomatous inflammation driven by immune system dysfunction. In the diagram drawn from the study's analysis across all 5 cases, common features include involvement of the epicardium, septum, multifocal scarring, and damage to the right ventricular free wall, present in over 90% of the cases. A particularly notable pattern begins in the septum and extends into the right ventricle, forming what's referred to as the hook sign, which you can see in B, a little bit on this gross pathology, C, and D as well. Or a triangle sign, fairly visible in D down here in the extending into the septum. So the pathologic images reveal widespread multifocal scarring that notably spares the endocardium. This helps differentiate sarcoidosis from ischemic heart disease, where damage typically starts subendocardially due to coronary artery blockages. What sets this apart is that what sets this study apart is that it exclusively used histology-confirmed cases, giving us a clearer understanding of how cardiac sarcoidosis typically presents, something that imaging studies alone didn't confirm with certainty. Summary: seeing multifocal non-coronary pattern damage, especially with involvement of the epicardium, septum, and RV free wall, helps suggest cardiac sarcoidosis rather than ischemic injury or myocarditis. Continuing in the same vein of visual characteristics of cardiac sarcoidosis, this is a typical cardiac MRI representation of the disease. This image highlights several classic features of cardiac sarcoidosis broken down across different imaging modalities. On the late gadolinium enhancement findings, the 2 images under short axis late gadolinium enhancement show scarring patterns typical of sarcoidosis at the base, and mid-septal levels, bright areas of enhancement indicate fibrosis that starts in the mid-septum. By the disease often extending into the right ventricle and free wall, it forms the hook sign up here, or the triangle sign, as mentioned previously, hallmarks of sarcoidosis. Interestingly, but probably not surprisingly, in early stages, imaging may reveal small, focal, late gadolinium-enhancing lesions. As the disease advances, the fibrosis becomes more extensive and irregular, disrupting larger portions of the myocardium. Also in this diagram, the bottom row of images showcase how additional cardiac MRI sequences help identify active inflammation. The T2 stir imaging in the bottom left detects myocardial edema, and bright signals here, particularly in the septum, suggest active inflammation indicating possible ongoing disease activity rather than just residual fibrosis. And then T2 mapping on the right, on the bottom right, provides a more quantitative assessment of those tissue characteristics. And elevated T2 values in the basal septum correspond with areas of inflammation, confirming the presence of edema and distinguishing active inflammation from chronic scarring. Despite all of that, there is significant challenges in the interpretation. While these late gadolinium enhancement patterns are highly specific for cardiac sarcoidosis, they are not always straightforward to interpret. One study showed that there is notable inter-observer variability, specifically shown here at about 52% agreement in quantitative measurement of the extent of late gadolinium enhancement between two different observers. Distinguishing cardiac sarcoidosis from other mimicking conditions such as myocarditis or amyloidosis requires expertise and often additional imaging modalities like FDG-PET and eventually biopsies. So getting back to the algorithm, after obtaining the cardiac MRI results, the management diverges based on the presence or absence of extracardiac sarcoidosis. If extracardiac involvement is confirmed and the MRI is positive, then you initiate treatment. Without extracardiac involvement, an endomyocardial biopsy is recommended. If the MRI results are inconclusive or negative in the extracardial sarcoidosis positive patients, you generally proceed with an FDG-PET. Some experts consider it even when positive cardiac MRI because it's more sensitive for active inflammation and then you can treat accordingly. A positive PET suggests active inflammation, helping to prompt initiating treatment. A negative result makes cardiac sarcoidosis highly unlikely. And if the PET is inconclusive, then you apply either the Japanese Circulation Society or WASOG or HRS guidelines. And if these are suggestive of cardiac sarcoidosis, then you treat. But that's kind of a gray area. And generally the differences here that I won't get into much are that the HRS criteria require myocardial tissue for confirmation of a definitive diagnosis. The JCS criteria allow a clinical diagnosis if greater than 2 major criteria are met. The JCS was also the first criteria to include possible isolated cardiac sarcoidosis. And some general critique to that is that these still require stricter validation, but generally they posit that when there's no extracardiac involvement and there's PET and gadolinium positivity concerning for cardiac sarcoidosis, and then at least 3 major cardiac criteria, then isolated cardiac sarcoidosis is diagnosed. The WASOG criteria includes extracardiac granulomatous inflammation and suggestive cardiac features and are very similar to the HRS criteria. If the MRI suggests that cardiac sarcoidosis, but there is no extracardiac involvement, then we consider isolated cardiac sarcoidosis. The next step is conducting an endomyocardial biopsy. A positive biopsy confirms the diagnosis by revealing non-caseating granulomas. If the biopsy is negative, then you can cautiously apply the JCS criteria, understanding that it's an exceedingly rare case to have isolated cardiac sarcoidosis. So for patients with confirmed extracardiac sarcoidosis, imaging findings often suffice for diagnosis. Cases of isolated cardiac sarcoidosis, endomyocardial biopsy remains critical due to its rarity and overlap with other pathologies listed in this table. The treatment of cardiac sarcoidosis hinges on careful risk-benefit assessment. For patients with definite or highly probable cardiac sarcoidosis, treatment should be initiated, especially if they present with clinical manifestations such as ventricular arrhythmias, advanced ventricular atrioventricular block, or heart failure with active inflammation. In probable cases, treatment decisions should be individualized considering the severity of symptoms, imaging findings, and potential risks of immunosuppressive therapy. For asymptomatic individuals with positive imaging, but no clinical signs, treatment decisions are less clear and should be personalized, balancing the potential for disease progression against the risks of immunosuppression. So the first line treatment is corticosteroids, specifically prednisone at a starting dose of 30 to 40 milligrams per day. And that remains the first line therapy, with higher doses reserved for life-threatening presentations such as cardiogenic shock. The dose should be tapered gradually based on clinical response and comorbidities. For severe cases, patients intolerant to steroids or those requiring prolonged therapy, early combination with a steroid-sparing agent like methotrexate might be considered, though robust evidence is lacking for upfront combination at the moment. Follow-up cardiac FDG-PET imaging at 3 to 6 months is then recommended to reassess inflammatory activity. If inflammation persists, escalation to a TNF-alpha inhibitor like infliximab can be pursued for refractory disease, though caution is warranted in patients with advanced heart failure due to potential worsening of the ventricular function. At the 3 to 6 month mark, the follow-up FDG-PET scan helps gauge inflammation levels. If inflammation has decreased or resolved, tapering prednisone down to 10 to 20 milligrams per day with plans to continue tapering if the patient remains stable is reasonable. However, if there's no improvement in inflammation or the inflammation worsens, the approach is to increase prednisone to the lowest previously effective dose and add a new steroid-sparing agent if one hasn't been used yet. If there's absolutely no response to treatment after a reassessment, it's time to reconsider the diagnosis. Are we dealing with something else entirely? Could the PET result be a false positive? If the patient is also having significant side effects from their medications or contraindications arise, this is when biologic agents like infliximab can come into play as the next line of therapy. If inflammation is resolved, immunosuppressive therapy can be gradually tapered off after 12 months of treatment. In cases of decreased but persistent inflammation, therapy should be adjusted based on the patient's clinical status, including the control of arrhythmias and the stability of heart failure symptoms. When inflammation is persistent or worsening, treatments should be escalated. This may involve adding biologics. It's also critical to reassess the diagnosis to, again, rule out sarcoid mimics or alternative pathologies. In refractory cases where inflammation remains uncontrolled or the disease progresses, advanced interventions like LVADs or heart transplantation become necessary. For patients exhibiting high-risk features such as ventricular scarring, implantation of an implantable cardioverter defibrillator is recommended to mitigate the risk of sudden cardiac death, even if the left ventricular ejection fraction is preserved. In summary, regular FDG-PET scans every 3 to 6 months, minimize corticosteroid use as much as possible by incorporating steroid-sparing agents. Biologics are generally reserved for refractory cases. Monitor for arrhythmias, progression of heart failure, and any systemic involvement, especially given the multi-organ nature of sarcoidosis. I found one prominent, interesting randomized controlled trial on sarcoidosis at Tufts called the CHASM trial. It's a prospective randomized controlled trial comparing low-dose prednisone and methotrexate combination to standard dose prednisone or prednisolone in patients diagnosed with acute, active, clinically manifesting cardiac sarcoidosis and not yet treated. The investigators hypothesized that low-dose prednisone and methotrexate combination will be effective as effective as standard dose prednisone and result in significantly better quality of life and less toxicity than standard dose prednisone for like 12 months. When evaluating cardiogenic shock, like the patient that I presented in the beginning, with an ultrasound, the first step is obtaining the right views. The key views are the parasternal long axis, parasternal short axis, apical four-chamber, and subxiphoid view. Start with the parasternal long axis by placing the probe in the 3rd or 4th intercostal space, marker towards the right shoulder. Then This gives a clear look at the left and right ventricles, left atrium, and mitral valve. Then if you rotate the probe 90 degrees for the parasternal short axis, it helps visualize the left ventricle in cross section. This is especially useful for identifying the D sign in right heart strain. Next, you can use the apical four-chamber view by placing the probe at the apex around the sixth intercostal space with the probe marker pointed left. This gives a clear image of all four chambers, allowing you to assess for dilation and wall motion abnormalities. Finally, the subxiphoid view is obtained by placing the probe under the sternum, marker facing the left. And then this view is especially helpful in critically ill patients and can be useful in detecting pericardial effusions when other windows aren't accessible, as it uses the liver for. I like to use the E-point septal separation because it's a quick, simple, and reproducible way of determining what someone's ejection fraction is, and it takes under a minute to perform. It does have some limitations, especially in patients with mitral valve pathology. It's a great tool for rapidly estimating ejection fraction. And this is a short video of it. You can see they use the M mode and then freeze it. And they're just gonna take a measurement between the A point septal wall, which is just spots here. And then based on that measurement, you can tell what someone's ejection fraction is. So the D sign is a helpful echo finding that shows right ventricular overload causing the left ventricle to appear D-shaped in the parasternal short axis view. This deformation occurs due to the right ventricle pushing the septum into the left ventricle. While it doesn't tell us the exact cause, it helps differentiate between pressure and volume overload. If the D shape appears in both systole and diastole, then think pressure overload. If the D shape only appears in diastole, then think volume overload, which could be due to conditions like tricuspid regurgitation, aggressive fluid resuscitation, lots of things. And I think these GIFs kind of help demonstrate what it really looks like, the D sign. This is McConnell's sign, and I'm not good enough to describe it, so I'll just. This is a case that I had that I thought was very surprising. So this was a 66-year-old female with a past medical history significant for hypertension, hyperlipidemia, prediabetes, venous insufficiency, obstructive sleep apnea, bilateral lower extremity lymphedema, and obesity. The patient presented to Unity Hospital after experiencing a syncopal episode without a prolonged loss of consciousness. She recalled waking up on the floor but did not remember falling. The last memory she had was walking from her bedroom to the kitchen. Additionally, she reported lightheadedness on exertion, particularly when climbing stairs, which had been recurrent up until the day of presentation. Upon arrival to the ED, her vitals were as follows: a blood pressure of 90/70, heart rate of 108, temperature of 36, respiratory rate of 16, oxygen saturation of 95% on room air. Orthostatic vitals were obtained on the scene by EMS, and initial labs were notable for mild leukocytosis of 11.7, lactic acid of 1.3, creatinine of 1.0, elevated troponins ranging from 272 to 287 with a delta of 15. Her EKG demonstrated normal sinus rhythm without ST elevations or T-wave abnormalities, but did show a prolonged QTC of 647. A chest X-ray showed no acute disease. Given her elevated troponins and hypotension, cardiology was consulted. They recommended fluid resuscitation with D5, half normal saline, and potassium optimization with plans for reevaluation in the morning. At this point, the differential diagnosis included several possibilities: orthostatic hypotension due to intravascular volume depletion, cardiac syncope secondary to ischemia or arrhythmia, and medication-induced hypotension due to her antihypertensive regimen. She was admitted for further evaluation of syncope and elevated troponins. She received a 1 liter normal saline bolus, potassium supplementation, and IV magnesium. A transthoracic echo was ordered to evaluate for possible cardiac causes of syncope given her elevated troponins and prolonged QTC. Remained on telemetry for continuous cardiac monitoring and was kept on fall precautions. Physical therapy evaluation was also initiated. On examination, the notes read that she appeared ill, but wasn't toxic. Cardiovascular examination revealed a regular rhythm with tachycardia, normal heart sounds without murmurs, rubs, or gallops. Pulmonary examination was unremarkable, and there was no respiratory distress. Her abdomen was soft, non-tender, without distension. A notable finding was significant bilateral lower extremity edema, consistent with her known history of venous insufficiency and lymphedema. So the leading diagnosis at that point was orthostatic hypotension due to intravascular volume depletion. However, given the elevated troponins and prolonged QTC, cardiac causes such as arrhythmias, myocardial infarction, structural heart disease were also considered. Chlorthalidone and lisinopril were held due to hypotension, while atorvastatin was continued. Further cardiac evaluation was pending echo findings. Additionally, the prolonged QTC raised concerns about possible arrhythmogenic event. So any thoughts on this diagnosis right at this moment? So here is her EKG, and I won't show it too long. The following morning, the patient continued to report persistent dizziness and increasing thirst. Despite receiving initial hydration, her blood pressure remained low, and she had intermittent tachycardia. Vital signs showed a poor trend. Her blood pressure ranged from 90/60 to 112/76, with heart rate fluctuating between 96 and 110. Oxygen saturation remained 95% on room air. On physical examination, she was alert and oriented, but continued to experience dizziness. There was persistent tachycardia, and her capillary refill was slightly prolonged, taking 2 to 3 seconds. Her lower extremities were notable for leg edema, though there was no tenderness over the venous distribution. She had no JVD, clear lung sounds, and a soft, non-tender abdomen. Later that afternoon, the patient remained tachycardic and symptomatic despite receiving an additional liter of fluids. Notably, she mentioned recent long-distance travel to visit her late mother's property, only about 30 minutes. At this point, it started to dawn on me, maybe she has a PE. But I was confounded. If she was kind of shocky, why was she mentating normally and also satting normally? So we ordered a stat CTPE, but it didn't get completed for about 3 hours. In that time frame, she became more symptomatic, so maybe that was a good thing that it was delayed. And she ended up on oxygen. This ended up being her CT scan. Massive PE. Technically, based on her clinical criteria, right up until this point, her blood pressure was soft. And so then, interestingly enough, she ended up being stable enough to undergo ECOS-directed, catheter-directed thrombolysis, and that was successful. She ended up being discharged on Eliquis, and this was a case that, in retrospect, had a ton of signs of PE from the get-go. The Canadian syncope rule was very high, which I had just gotten done listening to a podcast about a week or two before I had this patient. In that population, the prevalence of PE is likely 20 to 30%. Then, if we look at her EKG, it had all the classic signs of a PE that we learn about, the S1, Q3, T3. And thankfully, she did okay. If you look here, you can see S wave in 1, showing that she has right axis deviation, Q wave, and T wave inversion in